Time to shift our focus from the thyroid to those little organs right next to the thyroid. Just hold still. They're right. No, not that. That's a lymph node. They're back tucked right underneath the upper and lower poles of each thyroid lobe. Just a little deeper, I think. That's it. The parathyroids. Right. Well, where should we start? Well, there are 4 of them. Just in case you receive 3 penetrating neck injuries. You know, that 4th one should be fine. Evolution and stuff. And they're mostly composed of chief cells that secrete parathyroid hormone. That's right, we're bringing back the sketchy PTHDs. In this sketch, we'll cover what happens when those little parathyroids cause too much parathyroid hormone release. That's hyperparathyroidism, as well as too little parathyroid hormone release, or hypoparathyroidism. The first thing to remember is that disorders of the parathyroids can really throw serum calcium concentrations out of whack, which impacts almost every organ in the body. Seriously, neuro, renal, cardiac, you name it. So in this scene, we join our PTHD scientists in their newest entrepreneurial venture, the Calcium Ice Cream Lab. It's one of those nifty liquid nitrogen instant ice cream kind of places, and it's all the rage. They've got this Bose-Einstein condensate that's served at like 2 Kelvin. Ugh, so good. Anyways, let's head to station number 1 where we can put in our order. The first thing to notice are those 4 little buttons next to her thyroid bow tie. Reminiscent of the parathyroids, wouldn't you say? Well, pair those with that big number 1 sign, and we're talking primary hyperparathyroidism. Primary disease means that the pathology causing hypersecretion of PTH is occurring right in the parathyroids themselves. It's not some indirect effect from another organ, like the kidney. We'll see that at station 2. Primary hyperparathyroidism is predominantly a disease of older women, which is why the first staff member is a female PTHD specifically. This disorder is characterized by increased free calcium levels, also called ionized calcium, with a concurrently elevated, or inappropriately normal, parathyroid hormone level. As always, hypercalcemia is represented by a big cup of calcium ice cream. Primary hyperparathyroidism is actually one of the most common causes of hypercalcemia, but the majority of cases are asymptomatic and only brought to the patient's attention by routine blood work. We'll get to where all that calcium comes from and what kind of symptoms hypercalcemia can sometimes cause in a sec. But first, what makes the parathyroids have a temper tantrum in the first place? The majority of cases, around 85%, of primary hyperparathyroidism are caused by a single benign parathyroid adenoma. To remember benign adenoma rather than carcinoma, just remember this mad scientist mascot urging patrons to add toppings. Most cases of parathyroid adenoma are sporadic, but there are 2 rare causes of familial hyperparathyroidism: multiple endocrine neoplasia type 1 and type 2A. Both are autosomal dominant disorders associated with tumors located in multiple endocrine organs. And both are covered much more extensively in the next video featuring the men in slacks. But for now, just know that the leader, Agent P, represents Men 1, and his sidekick, his number 2, Agent A, is Men 2A. Men 2B is that big, gnarly-looking alien dude, and he will not be making an appearance here. Their placement in that movie poster is also important to notice. Primary hyperparathyroidism in Men 1 is usually due to parathyroid adenoma formation, which is why he's closest to the mad adenoma scientist guy. Men 2A, however, is more commonly associated with diffuse parathyroid hyperplasia. So below his side of the poster, we've got our next ice cream PTHD, with a set of big parathyroid buttons. We'll get back to this diffuse hyperplasia thing in a bit. First, let's talk histology of parathyroid adenomas. And for that, we'll need to bring in the chief scientist, with his chief badge covering one of his parathyroid buttons to represent those parathyroid hormone-secreting chief cells. Parathyroid adenomas are composed of well-encapsulated sheets of chief cells with less adipose tissue than the surrounding normal parathyroid gland. It kind of looks like this focal cluster of purple sprinkles on the ice cream here. Also, notice that this to-go order is well encapsulated by that plastic cover. Alright, take a look at the other buttons on the chief's coat. They're kind of tiny and atrophied and falling off. See? This perfectly represents how, with a parathyroid adenoma, the surrounding parathyroids often atrophy from non-use. The adenoma secretes too much parathyroid hormone, leading to hypercalcemia. See those splotches of calcium ice cream? Which suppresses the native glands. All right, back to that guy with the oversized buttons. The second most common cause of primary hyperparathyroidism is parathyroid hyperplasia, only accounting for about 6% of cases. In parathyroid hyperplasia, there's an enlargement of all 4 glands with a corresponding hypersecretion of PTH from chief cells. Finally, a very rare cause of PH is a primary parathyroid carcinoma, which accounts for less than 1% of cases with primary hyperparathyroidism. These tumors enlarge one parathyroid gland, have a dense fibrous capsule, and are difficult to distinguish from parathyroid adenoma. The best way to diagnose these guys is to look for invasion of surrounding tissues or metastases. So we've placed a tiny crab spoon outside this encapsulated mass, metastasizing its ice cream across the counter. All right, we've covered the causes of primary hyperparathyroidism, characterized by elevated parathyroid hormone and elevated calcium. Let's now go over the clinical effects. Oh yeah, don't forget to check out the vitamin D and calcium sketchy farm video for a detailed illustration of the interplay between parathyroid hormone and vitamin D, both of which affect calcium and phosphate homeostasis. One of parathyroid hormone's effects is to increase activity of 1-alpha hydroxylase in the kidney, which promotes the synthesis of 1,25-dihydroxyvitamin D, also called calcitriol. Just think of this PTHD putting the finishing touches onto that calcitron helper bot. Turns out our entrepreneurial PTHDs have brought along their very own calcitron robot to help out in the shop, where his calcium retrieval duties are as important as ever.
I am programmed to obey.
Calcitrol increases both calcium and phosphate absorption from the gut. Likewise, our calcitron robot receives some liquid calcium milk along with some chilled pea-shaped phosphate mixer attachments from the GI-themed fridge. Parathyroid hormone also exerts its own direct effects, this time at the kidney. Notice that the mixer next to our chief PTHD is kidney-shaped. Here, parathyroid hormone causes increased calcium resorption from the proximal tubule, but increased phosphate excretion, driving hypercalcemia and hypophosphatemia. This is depicted by that raised scoop of calcium ice cream, with a corresponding drop in those pea-shaped phosphate mixers. So, to sum up, hyperparathyroidism means high parathyroid hormone, usually from an adenoma, though sometimes hyperplasia, and rarely cancer. This leads to high vitamin D, increased calcium absorption from the GI tract and kidney, and low phosphate. With this in mind, let's separate the clinical effects of primary hyperparathyroidism into 2 categories: the direct effect of high levels of parathyroid hormone and the effect of high calcium levels, which affects pretty much every organ system. The combination of these effects can be summed up with a pretty nifty rhyme: bones, stones, Game of Thrones, groans, and psychiatric overtones. I want to emphasize again, though, that these symptoms are pretty rare in the United States, and the most common presentation is actually asymptomatic primary hyperparathyroidism. So just keep in mind that these are the classic symptoms, and we'll start with the direct effects of parathyroid hormone. First up, bones. A classic. Think back to Sketchy Farm one more time. Highly elevated parathyroid hormone levels stimulate osteoblasts to release rankle, which in turn activates osteoclasts. This was represented by the PTHD convincing the osteobuilder to give the rankle crank drill to the classmates. Those activated classmates then started wreaking havoc on the bone display, just like activated osteoclasts. Bone breakdown leads to calcium resorption into the serum. Well, those activated osteoclast classmates aren't done destroying private property yet, because we've got a couple right here at the ice cream lab. The classic manifestation of primary hyperparathyroidism-related bone disease is called osteitis fibrosis cystica, and it's represented here by this bone-shaped loyalty card getting punched with cystic holes. The basic idea here is that osteoclasts go crazy and reabsorb too much bone. Concentrated areas of overactive osteoclasts can lead to bone cysts and brown tumors. Notice how the holes punched out in the card look kind of brown, because we can see the brown floor through them. Brown tumors are a collection of osteoclasts intermixed with fibrous tissue and poorly mineralized woven bone. and the brown color is due to hemosiderin deposition. Another classic radiological finding is subperiosteal thinning of cortical bone, represented here by this cleaner lifting up the tablecloth. The periosteum, if you will, and cleaning underneath. That's the subperiosteum. His clothing is thinning too, in the common areas to see subperiosteal thinning. The phalanges, the clavicles, leading to a tapered shape of the clavicles, and the skull, leading to a salt and pepper appearance. This guy should probably take a break from the cleaner products. Trash duty or something. We've given this guy salt and pepper hair too, for good measure. Again, probably from the chemicals. All this bone disease manifests clinically as bone pain in any area that's affected by the lytic lesions or subperiosteal thinning. Also, look out for high alkaline phosphatase on labs, an enzyme normally found in liver and bone. In the setting of primary hyperparathyroidism, ALK-Phos starts to leak into the serum due to excessive bone breakdown. At Sketchy, alkaline phosphatase is represented by chalk. So we've placed a box of chalk up here at the counter. Check out our hepatobiliary unit for more causes of elevated ALK-Phos due to hepatobiliary dysfunction. And last bone thing, I promise. Besides lytic lesions, patients with asymptomatic hyperparathyroidism may, instead, present with decreased bone mineral density or osteoporosis. So we've included a low-density bone here, snapping under an otherwise manageable weight. All right, so all this bone disease was a direct effect of high circulating parathyroid hormone. The second direct effect I want to mention involves those two yellow test tubes held by the ice cream lab mascot. Yep. Increased levels of parathyroid hormone impair proximal tubular bicarbonate reabsorption, effectively creating a type 2 renal tubular acidosis. This effect is pretty rare unless the patient has extremely high PTH levels. Remember that renal tubular acidosis is a non-anion gap metabolic acidosis. Check out the acid-base sketch and the renal tubular acidosis sketch for more details. Okay, onward to the clinical effects due to hypercalcemia. Side note, the hypercalcemia in primary hyperparathyroidism is usually asymptomatic. The most common cause of symptomatic hypercalcemia? Cancer. We'll go over all of the etiologies of hypercalcemia at the dairy, over in the electrolyte chapter. So definitely check that out. All right, we did bones. Time to talk about stones. Patients with chronic hypercalcemia are at an increased risk for calcium stone formation due to hypercalciuria. So we've placed a big stone here on this kidney-shaped tray holding down some coupons. Nephrolithiasis is actually the most common clinical manifestation of primary hyperparathyroidism, occurring in 10 to 20% of cases. All right, from stones to thrones. The porcelain throne, that is. Chronic hypercalcemia can cause a defect in renal concentrating ability, leading to polyuria and polydipsia. The mechanism is incompletely understood, but may involve downregulation of aquaporin 2 channels and deposition of calcium in the medulla of the kidney, messing up that osmotic gradient. And before we move on from the kidney, it's important to note that if hypercalcemia is severe and long-standing, it can also lead to metastatic calcification of the renal tubules and end-stage renal disease. Luckily, rare, except in cases of pre-existing renal disease. To show renal calcification, we have a kidney-shaped tray with a bunch of little samples of calcium ice cream. Notice, too, all that ice cream on his shirt. Metastatic calcification can also lead to calcium deposition in the brain, skin, and even the lungs. So, next time, maybe just one at a time, buddy. All right, that's it for thrones. Next up, groans. As in GI groans. That plunger is our recurring symbol for constipation. Constipation may be due to calcium imbalance causing decreased smooth muscle tone and abnormal autonomic function. Here's another groan for you. Peptic ulcer disease. Calcium is a potent stimulator of gastrin release in the stomach, resulting in hypersecretion of gastric acid. This, in turn, can lead to peptic ulcer disease, as depicted by the erosion in the floor from chronic exposure to that acidic lemon water. Pancreatitis. Yeah. Turns out that high levels of calcium can injure the pancreas too. This could be due to calcium deposition in the pancreas